Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're doing another Kahoot and we're going to be covering prioritization and delegation. I have numerous videos on prioritization and delegation. Why am I ramming it down your throat? Because so many questions on NCLEX are based on prioritization and delegation. You guys cannot get away from it. You have to understand it, and you have to understand it well if you want to be successful on NCLEX. Before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it. Go ahead and give it a thumbs up now so you don't forget. Subscribe to my channel if you haven't done so already. And be sure to check out my website, guys. I have so many wonderful resources available for you on my website. You can sign up for a consultation session. Maybe you want to pick my brain about something. You can sign up for a tutoring session. One-on-one private tutoring with me. You can sign up for a next generation NCLEX review session where I offer part one and part two. Part one, I teach you how to think like the test writer. I teach you about prioritization. I teach you about delegation. I teach you about critical thinking. In part two, we actually go over NCLEX type questions, rationales, and how you need to apply them to the type of questions that you'll expect to see on your exam. I also have audio lessons. If you're a current student and you are struggling, you have to do really well on your next exam. Check my audio lessons and see if I have one that matches the subject matter on your next test. Guys, I've got some great things coming down the pipeline for you. My Nexus Nursing Testing Bank is almost ready. I'm putting the finishing touches on it, and it's taken me a while to produce this for you. I wanted to make sure I had a body of work that was deserving of you guys. Okay. Next generation NCLEX, when it changed, my students, I'm so grateful. You guys take your boards, you come back and you tell me what you saw. And I don't care about what you chose as your answer. I don't know if you chose the right answer. What I care about is the content. What did you see? Right. And the feedback that I was getting, it does not matter what state you're testing in. There are certain subjects, there are certain things that NCLEX asks about. Doesn't matter if you're in Utah, Kansas, Michigan, Kentucky, New York, it doesn't matter. Students are seeing these concepts over and over and over again. I have a pretty good idea of not the questions on the test. I don't know what NCLEX is asking you, but I have a good idea of what students are seeing, the important things that you need to know. So that's what I have emphasized on my test bank that's rolling out very soon. So keep checking my website. It's coming out soon. I'm very excited about presenting this to you guys. So anyway, my website is a wealth of resources for you guys. Almost daily, you can find me covering a variety of nursing topics across my social media platforms, TikTok, Instagram, Facebook, YouTube. My handle is the same everywhere, Nexus Nursing. All right, guys, without any further ado, let's get started. Prioritization and delegation. First question. You are caring for four patients. Which patient are you going to see first? Is it the patient with COPD who has an oxygen saturation of 90%? Is it a patient with diabetes complaining of blurred vision? Is it a patient post cholecystectomy who reports severe abdominal pain? Or is it a patient with a suspected pulmonary embolism and chest pain? Which patient do you see first? In other words, which patient do you prioritize? Very good. You better prioritize that patient that's at risk for a pulmonary embolism. They have chest pain. Listen, if you didn't catch the pulmonary embolism part, which is a medical emergency within itself, you should have caught the chest pain part, which is a medical emergency within itself. Think about it. Can you survive without lungs? No. Can you survive without breathing? No. Can you survive without a heart? Absolutely not. Right? Whenever you're being asked which patient you're going to see first, what you're really being asked is which patient takes priority. Whoever is at risk to the fastest, that's going to be your priority patient. Okay? Now, 15 of you guys went with the patient with COPD that has an O2 sat of 90%. I see how you see O2 sat of 90%. You're like, uh-oh, go see them first. But look, that patient's got COPD. They've got chronic bronchitis. They've got emphysema. They've have COPD. Guess what? They're going to have a low O2 sat. Does that mean we don't care? We're not going to assess them? No, it doesn't. It just means their life is not at risk, not like the person with a suspected PE or chest pain. Only 5 of you guys chose the diabetes with blurred vision. Good. Good. Worst case scenario, okay. You're hyperglycemic. Worst case scenario, you're about to lose your eyeballs. But guess what? Did you die? No, you're still alive, right? And then last, 10 of you guys chose the patient who just had a cholecystectomy and they're repeating severe abdominal pain. Yes, that patient needs to be assessed because they just had surgery. And when you have surgery, yes, you're going to be in pain, but the pain is severe, which tells us something is wrong. But guess what? Even that patient's life is not going to be at higher of a risk as the person with a suspected PE, chest pain. You did not catch the pulmonary embolism. You did not catch the chest pain. Did you at least catch the suspected? You want to know what that tells us when we see that word suspected? That means we don't even know what's wrong with the patient. We think we know, but we don't know. So what do we have to do? Assess them and find out. That means you got to go check them out, right? All right. Guys, make sure you pick up what I'm putting down. This is how NCLEX gets you. Let's keep going. Which task would be appropriate for you to delegate to an unlicensed assistive personnel? Would it be assessing the patient's pain level after medication? Would it be monitoring the patient's IV infusion for infiltration? Would it be assisting a stable patient with ambulation? Or would it be to administer oral medications to a stable patient? What would you delegate to your UAP? Very good. Assisting what kind of patient with ambulation? A stable patient. There's your key. Let me explain to you. Unlicensed assistive personnel, they cannot assess, they cannot teach, they cannot assess, evaluate. They can remind, right? They can transfer stable patients. They can ambulate stable patients. They can pick up medication from the pharmacy and bring it to you. They can pick up blood from the blood bank and bring it to you. They can pick up supplies and bring it to you. They can take vital signs on a stable patient. They can perform activities of daily living. There are lots of things that a UAP can do, but they can't assess, they can't monitor, they can't give drugs. So the only option here would be to assist the patient with ambulation. Now remember, a stable patient. What if you have a patient that just had a stroke and this is their first time ambulating? Can you delegate that to a UAP? Everybody on the live, yes or no? Answer quickly. Can you delegate that to a UAP? No. Why? Because they have a new change. They just had a stroke and this is their first time ambulating. The registered nurse must ambulate that patient, even though UAPs ambulate patients all the time. The reason the RN must ambulate this particular patient is because the RN has to assess this particular patient to see if they are stable enough. Okay? All right. You're working with an LPN. Which task could you assign to the LPN? Would it be administering IV push morphine to a postoperative patient? Would it be performing a sterile dressing change on a surgical patient? Would it be initiating a blood transfusion? Or would it be conducting the initial assessment of a new admission? Which are you going to delegate to the LPN? Very good. The sterile dressing change. Let me tell you something. I can't tell you how many of you guys, how many, not you guys, but how many students fail NCLEX. And let me tell you where they go wrong. Delegation. For some reason, you get scared and you want to treat that LPN or LVN as if they are UAP. And there's so many things that the LPN and LVNs can do. They can do sterile wound care changes. They can do Foley catheters. They can suction trachs. Yeah, there's so many things that they can do. NCLEX wants to see, do you know how to use your resources appropriately? Now, no, they're not going to be doing IV pushes. They can't do IV pushes. They can't do central lines. They can't give blood, right? So you wouldn't choose any of those. They can't, excuse me, they can't do new admissions. They can't do discharges. but they absolutely can do a sterile wound change. Excuse me, guys. I have the flu. I'm just getting over it. Which patient would you prioritize during morning rounds? Who are you going to see first? Is it a patient with 101 temperature after surgery? Is it a patient with chest pain rated 7 out of 10? Is it a patient requesting discharge teaching? Or is it a patient scheduled for a routine lab draw? Who are you going to see first? Very good. That patient with chest pain, 7 out of 10. Now, it's concerning that 43 of you guys went with the patient that has a fever of 101. Let's talk about this. Whenever you're asked who you're going to see first, again, that means who takes priority? Who is at highest risk of, right? When has a temp of 101 ever, anyone that you know? Now, let's talk about that chest pain. How many times have chest pain off somebody, right? What does that chest pain represent to you? Okay. Angina. That chest pain, the heart is screaming out because what? Lack of oxygen. It's not being perfused. Now, yes, sometimes the patient has chest pain and it's not angina. It's not an MI. The patient just has a GERD. They just have acid. But guess what? We're not going to know the difference unless we actually assess the patient. So when you have to, let me tell you something. You see how it said chest pain 7 out of 10? Even if it said chest pain 3 out of 10, you'd still go see that patient first. We need to rule out MI. By the way, another famous test question, you got a patient, they got chest pain. What, diagnostic test do you expect to be ordered? You expect the EKG, right? We're trying to rule out what MI. Even if it said 3 out of 10, you'd still go with that patient first. Any questions on the live? You guys good? I'm going to keep going. All right. Oh, let me talk to you about the other option. So anyway, after you saw that patient that had the chest pain, then by all means, please go see that patient with the fever of 101. That's a problem because any patient that has had an invasive procedure, our biggest nightmare are these three things: infection, right? Which we expect to, if they get infection, we would start seeing those signs and symptoms of infection after the first 24 to 48 hours. We start to see redness, the inflammation, increased WBCs, increased CRP, increased ESR, all those signs, the increased WBCs, all those signs and symptoms of infection. Second nightmare. What is my second nightmare? Oh, DVT or pulmonary embolism. And third one, after patient has had surgery, what is our third nightmare after? Oh, third nightmare after surgery is going to be hemorrhage, right? We're going to be looking at the blood pressure. Is it going down? Is the urine output going down? Is the RPC going down? Is the HNH going down? Is the heart rate going up? Is the respirations going up? All those things that would tell you that this patient's bleeding out somewhere. We're going to be watching out. Those three things. Anytime a patient has had surgery, those are our top three concerns, by the way. So anyway, after the chest pain, we're going to check the fever of 101. After the fever of 101, we're going to go ahead and do the lab draw of the patient schedule for a lab draw. And then last, we'll do our discharge teaching. Let me tell you something. Teaching is last. Why? That patient's stable. Okay? Let's keep it moving. Which task is appropriate for you, the RN, to delegate to the UAP? Would it be teaching a patient how to use a glucometer? Would it be documenting INO for a stable patient? Would it be administering a sub-Q insulin injection? Or would it be evaluating a patient's response to medication? Guys, don't forget, my Nexus Nursing Test Bank is coming out soon. Make sure you check out my website, nexusnursinginstitute.com. If you know, you know. All right. Yes, guys, very good. Documenting INO for a stable patient. Very good. Patient needs to be stable. They can do INOs. They can do vital signs. They can record and report. They can transfer medications. They can transfer drugs, they can transfer equipment, they can transfer stable patients, they can do ADLs, lots of things that UAPs can do. Make sure you know it. You delegate taking vital signs for a stable patient to a UAP. Okay, great. What's your responsibility? Is it to ensure that the task is completed correctly? Is it to delegate the task to another UAP if needed? Is it to document the vital signs without reviewing them? Or is it to ask the UAP to interpret the vital signs? What would be your responsibility? Very good. Before you even delegate a task to a UAP, you have to make sure that that UAP is competent to complete that task. What do I mean by that? Yes, UAPs are allowed to take vital signs on stable patients. Absolutely. Absolutely. But even though they're allowed to, before you delegate that task to a UAP, you have to confirm that they are competent. They know how to use the machine and know how to take those vital signs, because at the end of the day, guess who it falls on? You, the RN, which sucks. You get it from all angles, because if the healthcare provider orders the wrong medication, they order something that's contraindicated, and you go ahead and you administer it, even though it was ordered, guess who's thrown under the bus? Guess who's standing before the board of nursing trying to defend their license? You. Okay. Before you delegate to the UAP, you have to make sure that they're competent. And guess what? You got to go behind them and make sure it was done correctly. Ensure the task is completed correctly. One person chose asking the UAP to interpret vital signs. They're not qualified to interpret vital signs. They're qualified to record and report. They record the vital signs and they report it to you, the nurse, or they report it in the flow sheet. That is it. They are not qualified to interpret what it means. So that means if a patient has a temperature of 103, they're not qualified to interpret that it means they have a fever, that they have a temperature. Am I saying that they don't know how to think critically? Absolutely not. I'm trying to get you past your test. They record and report. That is it. All right, let's keep going. Which patient would you assign to a newly licensed registered nurse? Would it be a patient requiring teaching about insulin injections? Would it be a patient with a chest tube who needs assessment? Would it be a stable postoperative patient who needs discharge instructions? Or would it be a patient with unstable blood pressure needing titration of IV vasopressors? Very good. Whenever you get a question that tells you the RN is a new RN, or you get a question that tells you you have a student nurse, so they're not even a nurse yet, they're just a student, or you have an RN that is floating to your floor. When you get those three types of situations, it all means the same thing. You're going to give them the most stable patient. And out of these four situations that we're looking at, the most stable patient is the one that's ready to be out the door. The stable post-op patient that needs discharge instructions. Now, it's concerning 30 of you guys went with the patient requiring teaching about insulin injections. Do you know how fast insulin will off you? We don't play with insulin. Let me tell you something. If you ever get a question asking you which patient you're going to assess first, a patient that's hyperglycemic or a patient that's hypoglycemic, you want to know who you're going to run to? The patient that's hypoglycemic, because low blood sugar will you way faster than high blood sugar. At least when your blood sugar is high, you got polyuria, polydipsia, polyphagia. You have all those different processes. At least it's buying you time, right? But if you're hypoglycemic, boom, you're on the ground. So somebody who requires teaching about insulin that can cause hypoglycemia, you need a very experienced person, a very experienced nurse. We don't play with that. So it would not be a new RN. 8 of you guys went with the patient with are you kidding me? A patient with a chest tube. The patient has a chest tube. The fact that they have a chest tube, that's already an issue, right? So we're going to be very careful with that. Patient got a chest tube and they need assessment. You need an experienced nurse to do this assessment. So if something's wrong, they realize something's wrong. And I'm happy only 3 of you guys went with the patient that has an unstable blood pressure that needs titration. No, you need an experienced RN. But that patient who's about to be out the door, that needs discharge instructions, they've been taught already. They need that reminder. This is what you're going to do. This is what you're going to do. This is what we're going to do. We're going over the paperwork together. You can give that to the newly licensed RN. Now, just so you know, thank you guys. Everyone double tapping on that screen. I see you. Thank you. I appreciate it. Just so you guys know, where was I going with my train of thought? Oh, yes. Discharge teaching, only the RN can do that. I don't care how experienced they tell you the LPN or LVN is. It doesn't matter. They cannot do discharge teaching. Only the RN is qualified to do that for testing purposes, okay? Remember, guys, we're not talking about what happens in the real world, what happens in the hospital, what happens, in the nursing home. We're talking about a perfect world, which is NCLEX world. Daisy, thank you for sharing the live. Thank you. Which task can be delegated to an unlicensed assistive personnel for a patient on strict INOs? Would it be administering a diuretic, measuring urine output, assessing for signs of dehydration, or evaluating fluid balance? You're the RN, you need to delegate to the UAP for a patient that is on strict INO. Very good. Measure INO, all they're doing is what? Recording and reporting. That is it. They cannot assess. They cannot evaluate. They cannot teach. They cannot give medications. Very good. Which patient should be seen first in the triage? Would it be a patient with a sprained ankle? Would it be a patient reporting severe headache and slurred speech? Would it be a patient with a low-grade fever and cough? Or would it be a patient with mild abdominal pain? Who should be seen first in the emergency room if you were the triage nurse? Very good. Very good. The patient with what type of headache and slurred speech? Like, if you didn't even catch the headache part and slurred speech, which should lead you to what? What do you think's happening to this patient with the headache and slurred speech? Everyone on the live, type it in. What do you think is happening? What do you think's wrong with them? Headache and slurred speech. Yep, possible CVA, stroke. Very good. Very good. That's the patient needs to be seen first. If you guys didn't catch that, you should have caught that word severe. Whenever you see that word severe, that is a red flag to you. And usually that's the first patient you're going to see. Sometimes they'll trick you. They'll put severe and put something ridiculous. But for most of the time, you see severe, whatever that is, that's the patient that needs to be seen first. All right, which task is appropriate to delegate to the UAP in the long-term care setting? Would it be performing a bed bath for a resident? Would it be administering oral medications? Would it be assessing the resident's risk falls? Or would it be developing a care plan for a new resident? We're in the long-term care setting. What can you delegate to the UAP? I'm so proud of you guys. I tried to trick you and it didn't work. It doesn't matter what the setting is. It doesn't matter, right? You still are going to delegate to them What is within their scope of practice? Yes, performing a bed bath for a resident. If you ever get confused about, okay, can I delegate this or not? Just say to yourself, does this require critical thinking? If it requires critical thinking, you're not going to delegate it. Now, before I get all this hate mail in my comment section, let me be clear. I am not saying that UAPs do not know how to think critically. I'm not saying that. I'm saying to pass your test, that's how you have to think. Okay. Say to yourself, does it require critical thinking? Because in the NCLEX world, the UAPs have not been trained to think critically. They've been trained to record and report. Don't come for me in the comment section because when I respond, you're not going to be happy. Keep it cutesy. All right, let's look at the other options. Administering scheduled oral medications. They can't give meds, so that can't be it. Assessing a resident's fall risk. We know they can't assess. And then developing a plan of care. Guess what? Even the LPN or LVN can't develop a plan of care. Creation of the plan of care, changes to the plan of care, DCing the plan of care, only the registered nurse can do that. Okay? Someone said, why not blue? Let me see what is blue. Administering scheduled oral medication. Oh no! Giving medications. Let me tell you what UAP stands for. The U in UAP stands for unlicensed. Unlicensed what does the A stand for? Unlicensed UAP. Unlicensed something professional. Unlicensed, not administrative, what does the A stand for? Is it administrative? No, assistive. Thank you. I had a brain fart. Unlicensed assistive personnel. You don't have a license. How are you going to give the patient the medication? You crazy? Uh-uh. Uh-uh. The LPNs, the LVNs, the RNs, they can administer medications, not a UAP. A UAP does not have a license. An LPN has a license. An LVN has a license. An RN has a license, not a UAP. Thank you. Excuse me. Last question. Which patient should you assess first? Would it be a patient with stable angina requesting PRN nitroglycerin? Would it be a patient post-op day 1 with a temp of 100.2? Would it be a patient with asthma experiencing mild wheezing? Or would it be a patient with a tracheostomy who's experiencing difficulty breathing? Who is going to be seen first? Very good. That patient that has a tracheostomy and they still can't breathe, that's who you're going to go see first. They are at the highest risk of. Now, guys, let's remove that patient from the equation. The tracheostomy patient, let's remove them. When we come down to the patient with stable angina requesting PRN nitro, a patient 1 day post-op with 100.2, and a patient with asthma experiencing mild wheezing. Between those three, who would you see next? Tell me on the live. Very good. The asthma patient that's wheezing. You want to know what that wheezing means? Wheezing is the sound you hear of air trying to push through a constricted airway. So that's who you see next. All right. Who would you see third? Between the patient with stable angina requesting PRN nitro and the post-op day 1 with a temperature 100.2. Between those two, who would you see next? Okay, you guys are half and half. Let me tell you what the answer is. You see that patient with stable angina. Don't be fooled because it said stable. It's still angina. It's just stable angina. What's the difference between stable and unstable angina? If a patient has stable angina, that means that, sometimes their heart will not get enough oxygen. And so the heart will start to scream, and that screaming is a chest pain that they feel. But the reason it's stable is because it's predictable. They know what is going to give them that angina. Anything that exerts themselves, when they overexert themselves. So if they garden past 10 minutes, if they do what adults like to do in the privacy of their room, if they climb a certain amount of stairs, if they walk for a certain amount of time, anything they do that increases the oxygen demand, they can expect that they will have that chest pain. But once they stop, whatever that activity is, that chest pain goes away. It's predictable. That's why they call it stable. Okay? Unstable angina, you don't know what causes it. It comes at any time. And even when you stop doing whatever you were doing, you still have the chest pain. That's unstable. So don't be confused by that word, what's stable in front of angina. So after you saw that patient with the trach that can't breathe, you see them first. Then you go over to that patient that has asthma that's wheezing. You see them second. After that, you're going to go see that patient with stable angina that's asking for nitro. Let's talk about this, guys. They've got stable angina, but they're asking for PRN nitro. What does PRN mean? That means as needed. If they're asking for it, they feel like they need it. Why do you need it? You got chest pain. What's going on with you? Right? Yes, it's stable, but what's going on with you? We know, what does nitro do? Nitroglycerin, it causes vasodilation, helps the blood flow. Remember, the oxygen is in the hemoglobin's in the RBC's in the blood. So when you have that vasodilation, the oxygen goes where it needs to go. Great. But why are you asking for that nitro? That patient needs to be assessed. It's not an emergency. They need to be assessed right now. We have people who are worse off, but you still have to check them. And then last, you're going to go see that patient that is 1 day post-op with 100.2. Yeah, they need to be assessed, but it's only 100.2. It's 1 day post-op, right? Maybe there's infection that is starting to brew. Absolutely, you need to assess them. But that 100.2, it never put anyone 6 feet under the ground. All right? I love when she checks me. And guys, that is it. Excuse me. For this Kahoot. Lots more coming your way by the end of this week. Again, guys, please be sure to check out my website. I've got so many great resources coming your way. I'm very excited about the Nexus Nursing Test Bank that's rolling out soon. Be sure to check it out, guys. www.nexusnursinginstitute.com. All right, now let's see how you all did.